Hi, and welcome back to Abnormal Psychology. We're into Chapter 2, and we're going to look at the Diagnostic, Statistical Manual on Mental Disorders. That's the DSM. And it's the most widely accepted diagnostic system. Now it's in its 5th edition. Another widely used system is the International Classification of Diseases, the ICD, and it's published by the World Health Organization. And it's now in the 10th edition, and there's also a Canadian enhancements and modifications to the system, and it's known as the ICD-10-CA, which has been adopted as a Canadian standard for coding, reporting, and tracking health information. We'll still be focusing on the DSM-5 for our purposes, as it will help us understand how clinicians categorize psychological disorders. By knowing, clinicians can then determine how and in what treatment will benefit the individual the best. We're going to start with a review of the DSM-5 as a diagnostic tool and what and how does it aid clinicians. And then we'll follow this with methods of treatment, including biological, psychodynamic, behavior, humanistic, cognitive behavior, eclectic, group, family and marital therapy, indigenous healing, and computer-assisted therapies. It's a very robust field because it's been developed for so long and there are many conditions. So we're going to go around, we're going to start with, the classifying of disorders, and I want to emphasize, I come from the field of working with people with intellectual disabilities, and one of the acronyms, or one of the mottos was, label jars, not people. Classifying disorders, not the people. Classifying is at the core of scientific enterprise. Labels make communication about psychological disorders possible. An attempt to define and discover actual diseases, mental or psychological disorders, we just need to ensure that we remember people first. People are not their disorders. They are people first. They live with a disorder. They don't and are not that disorder. Even in our language, instead of saying the schizophrenic, we should be addressing the person who lives with schizophrenia, being careful not to have the label be the person, and that's paramount. The DSM uses specific diagnostic criteria to group patterns of abnormal behavior that share common clinical features. Now, the strength of the DSM includes its use of specific or specified diagnostic criteria to provide a picture of the person's disorder. Now, you're going to find these throughout your textbook, and they'd be helpful to help you understand how they make these determinations. Now, the weaknesses of the DSM include questions about some of the reliability and validity, which is really important in terms of research, and about the medical model framework. Additionally, there has been some criticism regarding its use of categorical approach to diagnosis of disorders, which has been addressed in the DSM-5 when it was released in 2013. Now, for clarification, and it's important, I mentioned this in, I think it was last week's video, around the terms validity and reliability, and we're going to chat with them about now. Validity is the extent to which a study or research instrument accurately measures what it's supposed to measure. Now, that may not always be the easiest thing to get your head around, but if you think about it as a weigh scale measuring. So if you look at the scale behind me here, a weigh scale measures weight. If you got on your scale at home and it says your IQ is 123, there's something wrong with your weigh scale. It's not a valid weigh scale. So weigh scales measure weight, not intelligence, creativity, or communication skills. Research tools can't do anything different than that. They have to do what they're supposed to do, not other things. And then the second point, reliability. Reliability is the extent to which a study or a research instrument yields consistent results. So essentially, if I get tested today and I get tested and my whole family and friends all get tested, the testing results ought to be consistent as an instrument. Again, we'll use the weigh scales. Weigh scales measure weight accurately. That is to say, when I wake up in the morning and jump on the scale, I get a weight. If I jump off the scale, stand and wait for 5 minutes and jump back on, I should have pretty darn close to the same weight. If I don't, then maybe my weigh scales aren't reliable. The DSM-5 classifies abnormal behavior patterns or mental disorders according to developmental models. This allows relevant lifespan information to be included. So if it's, not every condition emerges in childhood or adolescence or early adulthood, sometimes it's later in life. So we need to have it be able to travel through one's lifespan. So this lifespan information to be included in decision making around the diagnosis. Moreover, the DSM-5 deliberately employs dimensions rather than categories in evaluating abnormal behavior. When a diagnosis of a mental disorder is made, other pertinent details are gathered from the individual, such as a psychosocial and/or environmental conditions, which influence the persistence of that particular disorder maybe. The impact that the disorder has on areas of the individual's lives are also documented. So for example, a diagnosis of depression may have a significant influence on a student's ability to fulfill his or her typical role functions as a student or as a parent or as a sibling, as an employee. The DSM-5 has undergone structural changes such as the elimination of 5 levels of multi-axis system. That was the way they had done it in the DSM-4. A major reorganization and regrouping of disorders also occurred. New disorders were added, including disruptive mood dysregulation disorder, or DMDD, premenstrual dysphoric disorder, PMDD, and hoarding disorder. Now, disorders like Asperger's syndrome was eliminated in favor of a broader category named autism spectrum disorder. Now, we're going to transfer from the DSM-5, and we're going to be revisiting it all through the semester, but we're going to start looking at treatments. And here we're going to look at a wide variety of treatment options. But who provides treatment? Well, the majority of licensed mental health professionals in Canada are clinical psychiatrists, clinical psychologists, and social worker. In the cluster formed of psychotherapists and counselors, there remain a lack of common pan-Canadian titles that clearly define scopes of practice, with regulations varying among provinces. And so that makes it somewhat of a less than perfect environment to do diagnosis and treatment. We are only going to do a quick review of treatments, as there will be a review of treatment options as a part of each category of disorder that we go through. And as always, additional information is found in your textbook, so please have it available and be able to review that. And we're going to start with the biological approaches, which includes drug therapy, electroconvulsive shock therapy, and psychosurgery. Anti-anxiety drugs are aimed at reducing anxiety and reducing muscle tension, which can produce the sensation of anxiety. They include minor tranquilizers such as Valium. It may relieve short-term anxiety, but do not directly help people solve their problems. And that's an important distinction for everybody to be aware of. Barbiturates and sedative hypnotics like Halcion are common in these sorts of areas. Now, these anti-anxiety drugs are intended to reduce or depress certain parts of the central nervous system. You may want to revisit that to come back to see where that fits. However, it's been clear that anti-anxiety drugs can and do become psychologically dependent. In other words, you can get addicted. Additionally, tolerance, the psychological dependence, can be developed with regular use of benzodiazepine, which is an anti-anxiety drug, where more of the drug is needed to provide the same level of effect as previous levels. Now, this works the same as any addiction. Alcohol addiction, you get a certain effect from the alcohol, but after a while of constant use, you need more to get that same effect. It is the same with these medications. Short-term use of anti-anxiety drugs can be very effective. Care and medical support is needed all through drug therapies. One of the key things that needs to be done that often people don't know is you need to have a regular drug test once you started a medication to determine that it fits within a therapeutic range. You don't want it to be overly affected or underly affected. I don't know if underly is a word. Antipsychotic drugs or neuroleptics help relieve flagrant psychotic features, but regular use of most antipsychotic drugs have been associated with a risk of a disabling side effect. It's known as tardive dyskinesia. Now, a few of the people that I have worked with tardive dyskinesia, it looks an awful lot like Tourette's, but it's a side effect from excessive use of antipsychotics. And that's not on the individual, that's on the prescriber who didn't do a proper blood test to make sure things were variable and treatment that they would not remain on for an extraordinary long period of time. Antidepressants have been shown to be effective in treating depressive disorders and come in 4 classes. So the first class we'll touch on, I'm just going to name them. It's tricyclics or TCAs. The second is the monoamine oxidase, MAOs, and these are inhibitors. The third is selective serotonin reuptake inhibitors, that's the SSRIs. And then the last one is serotonin norepinephrine reuptake inhibitors, or SNRIs. Now, there are many issues to consider when exploring antidepressants, and they include things like the characteristics of the individual patient, the type and subtype of disorder, the awareness of issues of tolerance, and what other therapies are being used or might be needed. A lot of therapies are done in concert. They work together, medication and, say, cognitive combine. ECT, or electroconvulsive therapy. It's not something that if you don't need it, I wouldn't recommend asking for it. But if you do need it, it's shown to be quite effective for some issues. And this is often associated with very dramatic relief from very severe depression, but questions still remain about the side effects. Deep brain stimulation involves implanting electrodes within part of the brain that affects mood. There are some positive effects for mood elevation for severe obsessive compulsive disorder and Parkinson's. However, it is limited and not approved for other disorders like depression. Now let's move ourselves into the psychodynamic therapies. Now, psychodynamic therapies originated with psychoanalysis, and the approach to treatment was developed by Freud. Psychoanalysts use techniques such as free association and dream analysis to help people gain insight into their unconscious conflicts and work them through in the light of day with an adult, as adult personalities. We'll just get in here and we'll start talking about them. Now, often these therapies can last many months, even years. More recent psychoanalytic therapies are generally briefer and not as intense. Free association, essentially all you're doing is you're just sitting or you're laying back and you just continually talk about whatever comes to your mind. You just let your mind wander and say whatever comes to mind. It doesn't have to make sense. It doesn't have to be connected. It just talk. And the therapist sits out of sight, not like in a room, but out of your visual awareness. And after many sessions, the therapist starts to offer an analysis of any sort of patterns, disclosures, drawing your attention to potential connections. So it's highly doctor focused. Now, because of that element of being doctor focused, or transference is a term that was coined in relation to this type of therapy potentially. And it's through therapy that a client may not only interact with the therapist as a therapist, but might at times also as one important person in their life, almost like a friend. Now, this can be helpful in a sort of role play, but problematic as in the client's relationship when they expect the same level of caring and feedback from their therapist as they seem to be giving to the therapist. And that can cause a problem in providing that therapy. More recent psychoanalytic therapies are generally briefer and more intense. These newer psychodynamic therapies still look at the unconscious, but they're more focused in the present, and they sit face to face and play a more active role in a more engaging role with the client. Behavior therapy applies principles of learning to help people make adaptive behavioral changes. Behavior therapy techniques include systematic desensitization, gradual exposure, modeling, adverse conditioning, operant conditioning approaches, social skills training, and self-control techniques. Now, another group or approach is the humanistic approach, and it focuses on the client's subjective, conscious experience in the here and now. Here we're going to consider both person-centered therapy and emotion-focused therapy. Now, the first person we'll touch on in regards to the humanistic is Rogers' person-centered therapy, where he helps people increase their awareness and acceptance of inner feelings that had met with social condemnation and then been disowned. The effective person-centered therapist possesses the qualities of unconditional, positive regard, empathetic understanding, genuineness, and congruence. Alternatively, the emotion-focused therapy focuses on helping to recognize one's maladaptive emotions and discover more adaptive responses and emotions. Now, here the point is not to get rid of any intense or uncomfortable feelings. Instead, they encourage or support viewing these feelings and emotions as a call to take action for new and adaptive actions. And so a lot of these therapies do take some time to get to the realization before you can actually do some work. Cognitive therapies, well, they focus on modifying, remember cognitive and thinking, the maladaptive cognitions or maladaptive thinking that are believed to underlie emotional problems and self-defeating behaviors. Now here we're going to look at rational emotive therapy, cognitive therapy, and cognitive behavior therapy. We'll start with Ellis's rational emotive therapy, and it focuses on disrupting the irrational beliefs that support emotional distress and substituting more effective and adaptive behaviors for the maladaptive behavior and replacing them. Now, Beck's cognitive therapy focuses on helping clients identify, challenge, and replace these distorted thinking, such as a tendency to magnify negative events and minimize personal accomplishments. This approach can include homework, tying strategies into the patient's real life and reporting back the results. Donald Mickelbaum's cognitive behavior therapy, he's a Canadian out of University of Waterloo, and his cognitive behavior therapy attempts to integrate behavioral principles and cognitive techniques in a way that reduces or eliminates problematic behavior and changes dysfunctional thoughts and cognitions. And so there's a common thread in the cognition ones. It's about thinking, and the behavior ones, it's about the actions that we take. The eclectic therapists, well, they make use of multiple models of psychotherapy. In technical eclecticism, eclecticism is basically I pick a bit of everything, and so it's an eclectic mix. Therapists in this approach use techniques from different approaches without necessarily adopting the theoretical model on which they were based. In an interactive eclecticism, therapists attempt to synthesize and integrate diverse theoretical models. Now, and some of our issues can be best dealt with on a larger scale or within our own family. So group, family, and marital therapy can be our next series. Group therapy has several advantages over individual treatment, such as reduced cost or opportunities for shared learning, experiences of mutual support, and an increased utilization of the scarce therapist resources. The particular approach to group therapy depends on the orientation of the therapist. Family therapists, they work with the conflicted families to help them resolve their differences. Family therapists focus on clarifying family communications, resolving role conflicts, guarding against scapegoating in individual members, and helping members develop greater autonomy. Marital therapists, they focus on helping couples improve their communication and resolving their differences. Now, I've mentioned in chapter 1, the reference to how culture can determine and vary what's abnormal and not abnormal. We can also look in terms of our therapies. Some of the cultural variables can have a big impact on how successful therapies will be. And so we'll touch on the indigenous peoples and their view of mental wellness as a form of balance of physical, mental, emotional, and spiritual aspects, and is on a continuum from minimal to optimum. All people are seen as interconnected. Attaining optimal mental wellness requires that the strengths of not only the individual, but also the family and the community. The indigenous healing perspective and healing and wellness promotion are multi-leveled, targeting the individual as well as the family and their community, while respecting both the individual and the group, their language, customs, histories, and environment. Now, a newer area, and it's sort of new. When I've done counseling for quite a long time and done behavior consulting for some time. This computer-based interventions, I was doing computer-based counseling, if you will, almost 15 to 18 years ago. So it's not brand new, but it's much better now than it was. Computer-based interventions in therapy come in all forms, from online cognitive behavior therapy with a live therapist using a video chat service to self-guided behavior therapy for children with anxiety. Computer-based interventions for various disorders have a potential to dramatically expand and alter the landscape of treatment. Now, it's worth noting, and valuably worth noting, that we're going to touch now on some of the psychiatric commitment and patient rights. And this is important. The legal process by which people are placed in psychiatric institutions against their will is called psychiatric or civil commitment. Psychiatric commitment is intended to provide treatment to people who are deemed to suffer from a mental disorder and pose a threat to themselves or others. Legal or criminal commitment, by comparison, this involves the placement of a person in a psychiatric institution for treatment who has been acquitted of a crime by reason of insanity. Now, insanity is not a term used in the field anymore. It is a legal term, but it's not a psychological term. That person is entitled to due process. There needs to be deemed an imminent risk to self and others and limited time. Now that time frame is 72 hours. So limited time pending more information. Involuntary hospitalizations, involuntary hospitalizations, people voluntarily seek treatment in a psychiatric facility and they can leave of their own accord unless a court rules otherwise. So who's the most dangerous? Take a look. You'll find it in your textbook as well. How do we predict who is the most dangerous? We got person A, who is it the apparent drunk driver in person A? Is it the institutionalized psychiatric patient in picture B? Or is it the scheming corporate executive Bernie Madoff in C? Well, although information disclosed by a client to a therapist generally carries a right of confidentiality, the California Tarasoff ruling held that therapists have a duty or obligation to warn third parties of threats made against them by clients. Just so you know, this does not apply in Canada yet. Patient rights include the right to treatment and the least restrictive treatment. So techniques need to be less restrictive. The community over the institution, if it's available, is least restrictive. We have the right to refuse treatment, even if someone would be benefited from the treatment. If they are not of imminent risk, they can refuse treatment. Most people in need do not refuse treatment. Well, this completes an overview and an introduction to abnormal psychology. And we're going to begin in week 3 to explore different types of psychological disorders, the theoretical perspectives to explain them, and treatments options currently available. And we'll start next week with chapter 3, anxiety, obsessive compulsive, and trauma, and stressors related disorders. Now remember, I'm going to be doing those sorts of sections in 3 videos. I'll do it in description, causes, and treatment. And they will be in each week. All right, I hope this is getting to be exciting for you to see what was coming forward, and keep up the good work, everybody. We'll see you next week. Bye now.